Welcome to this webinar, an Introacoustics Academy webinar on oVEMPs, where I'd just like to make an introduction to the principles of the oVEMP and some of the clinical applications and so on. Now, my name's Michael Maslin. I'm an audiologist and an international clinical trainer with the Introacoustics Academy. And we're a team of audiologists who are with Introacoustics, and our role is to provide training and education in the various different audiological and vestibular tests and their clinical applications. And as mentioned from the slide, today's discussion is going to focus around one such vestibular test, the oVEMP, for ocular vestibular evoked myogenic potential. So we'll just unpack. Here we have a slide showing the content. We'll just unpack a little bit about the principles and origins of the oVEMP. We'll talk about some technicalities surrounding actually measuring an oVEMP, and then we'll relate our discussion to the actual clinical applications. Now, this starting slide is really just to remind ourselves of some underlying principles of anatomy, and in particular we can see the stapes highlighted in red there, and of course the stapes is the third in the chain of the ossicular chain of bones that transmit sound vibrations from the external environment to the inner ear. Where they propagate, those sound vibrations typically propagate along the cochlea, but a small point to note from this slide is the proximity really of the stapes footplate to the vestibule, which contains the two otolith organs, the utricle and the saccule. And this second slide, which just unpacks or zooms in on that a little bit more closely here, and we might be able to appreciate the way in which sound vibrations move into the here in the coloured zone. We have the membranous labyrinth. Sound vibrations move into that labyrinth through a sort of pneumatic system and propagate along the cochlea, since those sound vibrations moving at the stapes footplate are vented to the middle ear cavity via the round window. But when the sound vibrations reach a certain intensity, then they have enough energy to overcome the higher fluid impedance of the vestibule, and then they can be used to trigger vestibular activation. Now, the two main mechanisms by which we can introduce sound to the inner ear would be via the air conduction and the bone conduction route. And here I'm showing the air conduction, so it could be via an insert phone like I show here, an IP30, or of course it could be via a supraoral headphone. But in any case, we can see, I'm not displaying the cochlea here, but we can see the way sound vibrations, again reaching a certain intensity, may be forced to propagate through and overcome that high fluid impedance of the vestibule and propagate through there to trigger utricular and saccular activation. And what's noteworthy is the way in which both the utricle and the saccule can be stimulated to sound in this way. Although when we talk about the oVEMPs, as hopefully will become clear in a few slides' time, then we're really most concerned with utricular activation. And then this slide shows the typical or hypothetical route by which bone conducted vibrations can propagate through the temporal bones if the transducer is placed on the mastoid, but it's not the only place that a bone vibrator might be positioned. But you can see here those sound vibrations entering the ear from a slightly different angle, but again causing a complex pattern of both utricular and saccular activation. And while we have different air conduction transducers available, we also have different bone conduction transducers available. I'm going to talk a bit more about these in detail later on, but the two principal means for the oVEMP would be the mini shaker displayed at the bottom left there, and the more recent radio ear B81 audiometric bone conductor. So it's important to note here we have a cross section of the utricle, and it's important to note that we're using sound only just as a pressure stimulus, just to generate some hydromechanical force to move the endolymphatic fluid, and then as a result to push against the otolithic membrane and create transduction. So here we have a sound wave pushing, and it's noteworthy that we're not here talking about, although it is sound, an auditory evoked potential, but rather we're talking about a vestibular evoked potential, and that's demonstrated by patients who might be profoundly deaf, but still are able to exhibit a VEMP. It's important to note, though, of course, that those with a functional cochlear will hear the sound stimulus, and will also exhibit auditory evoked potentials too, but that's almost a side effect in this particular application. And but from an evolutionary sort of point of view, in lower animals, some certain fish and amphibious species, then these otolith organs are actually the primary hearing organ, and so it's not thought to have any functional or any important functional role in humans, but rather it's viewed as a vestigial throwback to our evolutionary ancestry. Certainly, at least this vestibular evoked potential isn't thought to be relevant to hearing, at least. And another important feature is that the VEMP that we trigger with sound isn't typically a physiological response. Here is a physiological response of the otoliths, in this case to a tilt of the head, and so we can see the head is tilted to the right, and that triggers an otolithic response in both the right and left utricles, and the resulting activation of the vestibulo-ocular reflex will drive the ocular counter roll. And I won't detail the complex pattern of interoral and intraoral firing here, as that can be viewed on a different webinar. The subjective visual vertical webinar talks about that, but suffice it to say that a normal tilt of the head, changing the head's position in the plane of gravity, or a translation would be expected to cause a pattern of activity bilaterally in a normally functioning person. But of course, when we come to the actual the VEMP, then we're moving via the aid of sound the otolithic membrane on one side, whilst the non-test ear is largely unaffected. And so this creates a non-physiological activation of the linear VOR and some resulting myogenic activity in the extraocular muscles, and in this case you can see a small perturbation in the position of the eyes. Now, just looking a little bit more into the reflex pathway itself. Now, I want to emphasize that we're really concerned primarily with the utricle, although the sound stimuli, whether it's by AC or BC, might be expected to stimulate both utricle and saccular, but here we're primarily interested in the utricle. And this is innervated by primarily the superior branch of the 8th cranial nerve, and via a series of reflex pathways, and these are shown in simplified schematic format in these two pictures here. Then we can trigger reflexive contraction in the rectus and oblique muscles. Now, if we were to stimulate, for example, the left ear, then we would be, from a test point of view, mostly interested in the response on the inferior orbit of the contralateral eye. So we often refer to the oVEMP as a contralateral response. Okay, now just before we move on and talk about some more technical details, I'd just like to mention that the response, of course, from the utricles in the neutral position is balanced and mirrored between the two ears. So, but there's a complex kind of morphological arrangement of hair cells across the macular layer there, and that morphological polarization is conveyed by the direction of the arrows. So both sides are multi-directional, and in any position when the head is moved in a physiological fashion, a tilt or a translation, some hair cells will be depolarized and simultaneously others hyperpolarized, and that complex pattern of stimulation is learned as a particular type of head movement. So here, for example, we have a roll, and that will activate some hair cells on either side of the striole or in both ears in one plane, in this case the roll plane, but simultaneously other hair cells won't be activated by that type of movement. And equally, this pitch movement will primarily activate some hair cells along the line of the arrows, as you see, whereas others that are more perpendicular to those polarization vectors won't be so activated. And that just comes back to the effect of air conduction and bone conduction stimuli. So we might consider the possibility that these different modes of presentation could stimulate the utricle and of course the saccule too slightly differently, where the AC presentation, you know, as you see here, you might expect that to give more of a transverse direction, whereas the BC stimulation is somewhat more complex, but with more of a lateral direction to the main thrust of vibration. So there are many similarities between the two, the AC and the BC, and we'll talk about where the clinical application of those two modes come in later. But just to note at this point that there are some also complex differences between the two as well. So I guess it's time that we actually had a look at oVEMP after all this. Okay, so here we have a very typical VEMP, and it's a biphasic response where you see a negative going peak around 10 milliseconds, which we can call the N1. Sometimes that's referred to as the N10. And then around 5 or so milliseconds later, in this case just a little bit longer than that, there's a positive going peak. That's often called the P15. In this case, we'll call it the P1. But as I say, that's just a little bit longer in this case. It's 6.5 or so milliseconds later. Okay, so we know from various physiological studies that both sets of muscles, the inferior oblique and rectus muscles, are activated by the oVEMP stimulus. But that N10 potential there is primarily driven by a contraction of the inferior oblique muscle, and it's excitatory, as we know from its sort of negative direction. So we've got a lot of overlapping responses here. So we've got the initial, as I say, the initial response from the inferior oblique muscle, but we might also expect some moments later some response from the rectus muscles. And if you're not sure about exactly the anatomical position, then don't worry, because I will try to convey that in the next slide. And of course, with the high intensity sound, you can see the label here showing 100 dB NHL. Then it's not a surprise that we might evoke other responses too, such as the post-auricular muscle response and auditory evoked potentials. So the bandpass filter settings and other recording parameters for these oVEMPs are very similar to some mid-latency responses, and so some of those peaks that we see at sort of 30 and 50 milliseconds in this trace might well be auditory evoked potentials. Now we can see from the montage, I'm going to talk a bit more detail about montage in a moment, but we can see here that when we stimulate the left ear, and as I alluded to a few moments before, then we would have an electrode under the contralateral, the inferior orbit of the contralateral, in this case right eye. And that might be the non-inverting electrode. The inverting or reference electrode in this montage is positioned on the chin. But let's just ignore the reference electrode for a moment and just consider the position of the non-inverting electrode that's just in the inferior orbit of the eye. And if we come onto this slide, then we can consider a little bit about gaze direction and the effect that that has on the position on the response as detected by the electrode just underneath there. And it's very common, in fact, highly recommended for the patient's gaze direction during this test to be averted upwards. And so we can see there that that has the obvious effect of moving at least slightly the belly of the muscle, of the inferior oblique muscle relative to the electrode. You might imagine that it just somewhat moves the belly of the muscles just slightly closer to the electrode. That's at least part of the explanation for looking upwards and why that might be important. There is another reason as well, which is supposed to be related to a certain automatic gain compensation mechanism, whereby a contracted inferior oblique muscle gives a correspondingly larger reflex. So the more contracted the muscle, the automatic gain of the reflex increases, so the reflex amplitude increases in parallel with the muscle contraction, and that increases the size of the VEMP. So the actual movement of the muscle that I just referred to, so there's these two parallel effects going on, but the movement of the muscle itself isn't huge, and so it may well be that that second mechanism, the automatic gain control, is perhaps the most important in the two, as to why we ask the patient to look up. But it would be useful for the patient to have a fixed point, so that during different steps of the test, for example, comparing left ear and right ear responses, then they're looking at the same point to aid repeatability. Now, as we look in the bottom right of the slide, we see the eye in profile view and head-on in relation to an electrode just in the inferior orbit, and we can see the effect of gazing up there, at least on the first of those two hypotheses, the effect of moving the muscle. But here's a demonstration of the different gaze position, and we can see a considerably larger response when gazing up as opposed to gazing ahead. In some people, it might be sort of 50% smaller or more, and if you were to gaze down, then the VEMP might be expected to disappear altogether. So that's a little bit about gaze direction, and also, of course, we've mentioned air conduction and bone conduction stimuli. And now I'd like to talk about electrode montage, and there's no standardized practice in my observations as yet, and this is one area where I've experienced some variation, let's say, in practice. But perhaps the most commonly used montage is where, if here we have a non-inverting electrode that's placed in the inferior orbit, and then the reference electrode, which is the white one, is immediately below that in a vertical line on the cheek. So here we have the left eye being recorded with the right electrode, the red electrode, and then the reference below that with the ground electrode in the forehead, and then the left electrode, the blue one, is placed in the inferior orbit of the right eye. So putting the inverting and non-inverting electrodes close together like this, the reason for this is generally given to help attenuate via common mode rejection far field activity. And so if we turn our attention to the right side of the slide here, then we can see some far field activity that's emanating from the temporal lobes, the auditory cortices, as you might expect in this test. We might expect this to happen, of course, the latency range that we're talking about. Then we might also expect subcortical activity too. But leaving that to one side for a moment, the point is this far field activity with two electrodes close together, one in the inferior orbit of the eye and then the other immediately below that, then they would be expected to be affected or sense that far field activity very similarly. And of course one is inverting and the other isn't, and so the response will be flipped and then tend to cancel itself out. And so that's one way to attenuate that unwanted, in this test, far field auditory activity. But of course there is some caveats to that. One caveat is that the response from the muscle, albeit a lot closer in physically to those two sensors, will still itself be attenuated. But secondly, there's the practical inconvenience, which is that here we're recording from the left eye, so it must be right ear stimulation. But when we want to record from the right eye for left ear stimulation, we have to take electrode off and reposition it under the eye, which is again just more of a practical consideration. It could be to some extent addressed by having the ground, so you've got these 4 electrode positions, and then when switching ears, you would simply switch the white and the black electrodes, the ground and the reference. That's one way around it. Of course, then you haven't got a ground on the midline. Perhaps a more elegant solution is just to have a midline reference electrode, and so that's what we're showing on this right hand side of the slide now, where we see the electrode, the reference electrode on the chin, and moving the reference electrode further away like this. Now it's on the midline, so there's no need to move the electrodes when we switch the ears of the test. What that will do is it will that now there'll be less attenuation of any of those far field responses, but of course it should also mean that there's less attenuation of the VEMP too, the actual response of interest. And so in this way you might argue it's a somewhat more of an elegant solution, but at the expense of some purity, because we'd expect some unwanted responses to creep into the measurements now. And so that's illustrated on this slide here. So in the upper trace we have the conventional sort of cheek reference position, very close to the inferior orbit of the eye, and we have a small VEMP, but we also have a small auditory evoked potentials. In the lower trace we have the chin reference, and we have a correspondingly larger VEMP, but also we have larger auditory evoked potentials too. So here we can see the actual amplitude of the response of interest, the N1 response there, and then this the P at the sort of 15 milliseconds or so. That peak-to-peak amplitude is near enough 7.5 microvolts, whereas the auditory evoked potential is somewhere around 3.5 microvolts. Where if we just have a look at similarly the effect here, so the response is more than doubled, the noise is roughly doubled. Okay. So I'm just going to unpack in a little more detail some further points on electrode montage, and here we're going to talk about the belly-tendon montage, which has been investigated by Jaz Sanhu and colleagues some years ago. What they did was they had 8 normally hearing, normal otological function adults, and what they did was they had the sort of standard inferior orbit of the eye, the electrode there, the red electrode with the reference immediately beneath it. And what we saw was, we can see on the right the corresponding VEMP there, the grand average from those 8 people. But then what they did was they systematically moved the electrode around the orbit of the eye, and we can see here in one of those positions where it's moved towards the middle there, then the polarity of the VEMP switches. So in making a kind of inference from the midline position to the medial position, there must be somewhere in between there where there's a null point where you'd see no VEMP at all. On the other hand, if we move the electrode towards the outer canthus of the eye, there's very little effect on the VEMP amplitude, but we're well away from that potential null point there. But what's of great interest in this study is their investigation of the belly-tendon approach, which is quite common in electromyographic recording, where in a sort of a standard montage, one electrode is the reference electrode is positioned on the tendon of the muscle, whereas the main sensor is sort of located over the belly of the muscle, and that's quite standard. And that would be, given the position of the inferior oblique muscle, that would be where the reference electrode is positioned on the inner canthus of the eye to give that belly tendon montage. And when these researchers did that, then they found a considerably larger VEMP amplitude, and so there's some interest in pursuing this as a routine approach to clinical practice. It isn't without controversy, and it may be that there's contamination issues and so on, but at least it reflects more closely what we do as standard in the CVEMP. And here I'm showing a picture from another Academy webinar on the CVEMP, where we see the standard montage for the sternocleidomastoid muscle, the standard belly tendon montage there. Some further considerations. Maybe now we'll turn our attention to the stimulus. And what we show here is a tuning curve for the oVEMP. This is where we present tone bursts of different stimuli on the x-axis, and then we measure the N1 P1 amplitude on the y-axis. And we can see the tuning curve where there's a kind of the greatest response is at that 500 Hertz region, which is very much in tandem with the CVEMP tuning curve, and then the response amplitude tails off as we increase the frequency. And so as a result, sort of the 500 Hertz with a few cycles, either a 2-2-2 cycle or a 1-2-1 cycle response, where I'm talking about the rise, plateau, and fall time. But a short onset response is considered favourable. Now there is a complex sort of tuning pattern where it may even be double peaked, and for very low stimuli, not shown on here, but a 100 Hertz, it may be that with the sort of the way in which the utricle isn't rigidly attached to the bones of the skull, and it's rather free floats, or at least a portion of it floats rather loosely, then this gives it a certain sensitivity to the lower frequencies, a lower resonance, and so there may be both low and high frequency tuning for the oVEMP, but for clinical purposes, in that region around 500 Hertz. And what of course we see here from this study cited is normative data for both thresholds, for latencies, and also of course for amplitudes, but that does depend very much on the stimulus parameters shown here and the electrode montage and so on. A relatively recent development is a chirp specifically designed for VEMP measurements, and it's a derivative of the CE chirp, which I'm just displaying in the top right of the trace, and that of course has been used and has been revolutionary in the field of objective threshold estimation for ABR and for ASSR, particularly amongst pediatrics. And that chirp there, which was shown in the top right, is designed to accommodate the temporal smearing effect of the cochlea. So it's curious that an up chirp is also effective in producing an advantageous oVEMP, but nevertheless it is, and we call that the CW chirp after the authors who designed this up chirp with this bandpass, which reflects the tuning that we were showing on the previous slide. So it has frequency components where the oVEMP is most sensitive, between 250 and 1000 Hertz. And here in the middle, the bars there show the chirp advantage here, as published in that citation, and using the montage that you see in the bottom right. So there's a statistically significant and useful amplitude advantage when using the CW chirp over the traditional 500 Hertz short duration tone burst. Of course, this is by AC. As we'll see, there may be reasons where for BC sounds, bone conducted sound, that 10 millisecond chirp is rather long when it comes to controlling the stimulus artifact, but certainly via AC that's a useful addition. Oops, gone one slide too far there. Now, before we think too much more about the analyses, I'd just like to mention some further clinical considerations. Of course, there's contraindications to this procedure, mainly surrounding the high intensity signals that we need for triggering an oVEMP. So the levels are high, and you'll see dial settings quite typically between 90 and 100 dB NHL. Now, using HL scales, because we're not talking about an auditory response here, behavioral or physiological, rather we're talking about a vestibular response. So in that sense, the HL scale isn't valid, except of course that the patients often can actually hear it, and we know using the HL scale intuitively, or at least those that are involved in hearing testing should know where uncomfortable loudness levels start to lie when using dBHL. So it's useful in that sense. But from the point of view of the vestibular system itself, then probably peak equivalent SPL is a more useful unit to work in. And when in that unit, from the point of view of loudness safety, then the levels shouldn't really exceed 135. And particularly, of course, we should consider the effect of noise exposure when doing multiple trials, like going through various CVEMPs and oVEMPs, perhaps of different frequencies, if plotting a tuning curve and so on. And anyone who's in particularly sensitive to sound, those with hyperacusis or perhaps troublesome tinnitus, Tulios, which is a vertigo sensation to sound, and of course loudness recruitment. Any patients like that, they might be either fully contraindicated or at least caution. A common question is the response reliability of the oVEMPs, and particularly in the older age groups. But I'll just draw your attention to this interesting study published a number of years ago, which shows that 10 adults in every decade from between 20 and 80 years old, and they used a number of stimuli, clicks, and I'm just showing here 500 Hertz tones, and they also presented signals by both AC and BC. And what they found, at least when the patient was gazing moderately upwards, was that 8 times out of 10 an oVEMP could be found, and that was roughly the same across the age span, with a very small, in this case non-statistically significant trend towards reduced amplitude as the patient grows older, which might well be a reflection of age-related vestibulopathy. So a handful of patients, they couldn't detect a VEMP except when they increased the sound level by just 5 dB, and also asked their patients to gaze more extremely upwards instead of just moderately upwards. Then more often than not, they could measure a VEMP. So 97% of the time we see here out of those 122 ears. Now I'd just like to move the discussion on to some very important recent developments when it comes to bone conduction. Now, compared to the air-conducted stimuli that we were just looking at a moment ago, where, as I say, up to 97% of the time we should be able to detect an oVEMP across the age span there, up to at least 80. But compared to that, in the air conduction, bone conduction vibrations tend to have been, at least when it comes to standard audiometric transducers, have tended to have been less effective as a stimulus. And the reason for this is relatively simple. The standard audiometric transducer, the B71, isn't powerful enough. So as a rule of thumb, when talking about vibrations via the transducer, then we need to typically get somewhere around 130 dB FL, and at its maximum output at 500 Hertz, then the B71 falls short of that sort of rule of thumb level. So the classical bone conductor that's available in many clinics has limited capacity for eliciting the oVEMP. And what that has meant is that people have been forced to revert to alternative methods, arrangements such as this, third-party devices such as the mini shaker, which are controlled by third-party amplifiers, and the mini shaker is powerful enough to achieve oVEMP stimulation, but of course never originally designed for use as a tool for people. And of course, with all this third-party equipment, then there's some substantial cost implication involved too. But the relatively recent development that I would like to just draw your attention to when it becomes relevant, not just to oVEMPs, of course, to audiological applications too, but in this context, the oVEMP, we can talk about the B81. And here I'm showing the maximum power output of the B81 audiological transducer as compared with the B71. So there's somewhere around approximately 20 dB higher maximum output. And when converted to force levels at 500 Hertz there, we can see that we just tip over that threshold that I offered earlier as a rule of thumb for where we might typically want our stimulation to be to effectively trigger an oVEMP. Okay, so here are some oVEMPs as triggered by the B81, and here we're using a 500 Hertz stimulus, but a knock-on effect, of course, is likely to be at these high levels is the stimulus artifact. And so what we're showing, there's a number of ways to control that. It's perhaps more complicated than the traditional ways to control it using air conduction, where, of course, with a tube insert phone, then we can physically separate the transducer from the electrodes, and of course the time delay as well, where the sound propagates through the tube, also temporarily separates the artifact from the response. But with the bone transducer, we don't have these options available to us. Of course, we can use alternating stimuli, although there are a number of complications associated, or potentially at least associated with this. And it relates to the way in which there's an asymmetrical activation of the utricle on either side of the midline point, the striola there. But another option we can take to try and control that stimulus artifact without any alternating polarity stimulus. So here I'm just showing a series of rarefaction responses, and another solution is to just shorten the duration of the stimulus. So in the upper trace we see a 500 Hertz response, and there's a relatively large stimulus artifact there, and it's pretty much contaminating the oVEMP in that 10 milliseconds region. But what I've done in the middle trace is I've just shortened the stimulus to a 1-2 cycle, so 5 cycles in total, and now the stimulus artifact is over before the N10 response begins, and we can even go a step further and reduce the response duration even further to just 3 cycles in total. And so the response artifact is now separated, and the oVEMP, being an onset response, is largely unaffected by this shortening of the duration. And we can see that by just comparing the latencies, and here you can see very little, if any, change in the latency between the middle trace and the lower trace. And similarly, the peak-to-peak amplitude is very, very similar, despite having shortened the duration of the signal. So with bone conduction, that's one way to get around the problem without needing to resort to alternating stimuli. Okay, so that's hopefully a useful overview in the necessary depth for the process of actually measuring VEMPs and some of the considerations. But now let us run through the analysis steps. So there are a number of different parameters that we might look at. First of all, of course, we're interested in is the response present in the first place, and we both check the suspect and non-suspect here if there was one, if there was a unilateral symptoms, for example. We'd be interested if there was a response present in its amplitude and latencies. We'd be interested in the size comparisons between the two ears, intraoral asymmetry, VEMP threshold in certain circumstances, and VEMP tuning curve. So I'm just going to quickly cycle through each of these and then mention the different patterns that you might expect with some of the more commonly associated pathologies where the VEMPs is useful. So amplitude, latency, and asymmetry. Well, first of all, We can think about the latency here of the two peaks here, the N1 and then the second peak there, and we can compare those to whatever normative range we might be referring to, which would have to correspond, of course, with the montage we're interested in, or using this mode of presentation, AC, BC, and all the other parameters would have to correspond. And there wouldn't be any objection, of course, to locally derived norms. Of course, we have peak-to-peak amplitude as well, and then there was the interoral asymmetry comparing left and right amplitudes. And here we have a 15% reduction in the size of the response on the left as compared with the right. So that covers amplitude, latency, and interoral asymmetry. What about threshold? Well, as you saw from a few slides ago, and hopefully conveyed in this slide too, it's very uncommon to see a response under normal circumstances at 80 or below. So the VEMP threshold is relatively high in otologically normal people. And here we can see the VEMP threshold is arguably for both ears in the sort of at 95 dB NHL there, although it is slightly smaller on the left, of course, in this case. But that would be a normal VEMP threshold. So it'd be rarely below 80. Another parameter would be tuning, frequency tuning, and we'll mention the relevance of this in a few slides' time. But plotting the VEMP at a fixed level, but changing the frequency of the sound. And so here you can see a number of different traces as we increase the frequency from 500 all the way through to 4000. And the VEMP tuning curve shows that peak, remember, between 500 all the way up to 1000, and then tails off very quickly. And so that's why we see large VEMPs for that sort of low frequency range, and then as we get to the middle and high frequencies, 2 kilohertz, 4 kilohertz, then the response drops off very, very quickly. Okay, right. So now let us just close with some discussion on some of the main clinical applications of the oVEMP. So of course, being an ear-specific test, then we can gain information on utricular function for those with unilateral or bilateral weakness, vestibular weakness, particular otolithic weakness, and there could be a number, almost any cause for this. So I'm being non-specific, but commonly it could be vestibular neuritis. Of course, it could be labyrinthitis. It could be some form of ototoxicity. It could even be after a prolonged noise exposure that there is thought to be some loss of vestibular cells too, vestibular hair cells. So almost any reason why there might be a unilateral or bilateral weakness. Another good example would be retrocochlear pathology, such as a space-occupying lesion like a vestibular schwannoma. All these various different pathologies might cause a pattern of reduced oVEMP activity. Now then, second on the list there we see third window syndromes, and in particular, although not exclusive to semicircular canal dehiscence, and in this case rather than a reduced VEMP amplitude like in the previous example, we might expect to actually see an enlarged or an enhanced VEMP amplitude. Third on the list, endolymphatic hydrops, is characterized by an alteration in that classic VEMP tuning curve that we were mentioning a moment or two ago. And then finally, of course, any type of central neurological abnormality where there was nerve conduction delay might expect to cause a delay in the VEMP latencies too, such as, for example, multiple sclerosis. But let's just go through some key examples, just illustrative examples for each of these four clinical applications. So the first one is a unilateral loss. And in this example, I've chosen the classic sort of vestibular neuritis, and sometimes, so this is an inflammation of the nerve there, the eighth nerve, and sometimes it might more commonly, in fact, specifically affect the superior branch of the nerve, and other times maybe specifically the inferior branch, and yet other times both branches of the vestibular nerve. But in the more commonly occurring superior nerve neuritis, then we can have a look at the oVEMP in conjunction with the CVEMP and then the video head impulse test to gain a differential diagnosis. And here's a common pattern. So we can see the upper two traces here on the left hand side of the slide, the CVEMP. Now that primarily reflects saccular function, and that saccular is innervated by the inferior branch of the nerve, so we see responses present both sides. This is a patient with left-sided neuritis though, and so when we turn our attention to the oVEMPs in the lower trace, while the oVEMPs on the right ear, the unaffected ear, are preserved, the oVEMPs on the left ear, as conveyed by the superior branch of the nerve, are either reduced or absent altogether. And that also corresponds with the video head impulse results, where we see again the two semicircular canals that are innervated by that superior branch. That's the lateral and anterior canals. There we have the reduced gain and the characteristic saccades. So there's also, of course, analogous pattern for complete nerve neuritis or inferior division. Perhaps the most closely associated vestibular disorder with the VEMPs is semicircular canal dehiscence, and this is characterized by a thinning or even absence of a bone that overlays the upper portion, the superior portion of the anterior or superior canal. And what happens from the symptoms point of view is very commonly associated with this Tullio's phenomenon, where sound now, because of that dehiscence, travels much more freely through the vestibule due to sort of reduced fluid impedance, and then that causes dizziness as in response to sound. But internal sounds, so this is vibrations can not only propagate from the stapes and then through the vestibule, but also in the opposite direction. So changes in intercranial pressure and internal sounds can migrate through that pathway through the inner, through the vestibule, and can also, of course, eventually be heard in the cochlea. So autophony, hearing one's own blinking and other sounds. Bone conduction, sounds are elevated even when the transducers place, say, on the ankle or another remote part of the body. Very characteristic. But from the point of view of VEMPs, then what we're interested in here is a diagnostic stimulus, and so that's where we present a sound to the ear. Because of that reduced fluid impedance, we might expect a greater deflection of the utricular macula there, but also, and perhaps more relevant to the enhanced VEMP pattern, is that because of the sound pathway, and I'm showing that with the flashing lines there, because of that enhanced sound pathway through the superior canal on the way to the dehiscent zone, then the canal afferents might also be activated, and so the canal afferents plus the utricular afferents combine to give that enhanced VEMP response. And so a nice example of that is shown here, where we see on the left, this is the non-suspect here, and it looks almost like there's no VEMP present, when in fact what we've had to do is scale out the response. In fact, the response from the left is perfectly normal, but we've had to scale out the response so far to fit all those enhanced responses on the right hand side that the left looks almost flat and absent. But we can see that that's the case, that the right ear is enhanced, because not only do we see a dramatically enlarged amplitude, but we also see a threshold which is abnormally low. So an abnormally low threshold should correspond also with an enhanced VEMP amplitude. And then the other one on the list, of course, was endolymphatic hydrops, and this is characterized by this overproduction or perhaps underabsorption of the endolymph fluid, which causes a distension of the endolymphatic membrane in the vestibule and potentially in the cochlea as well. And the cochlear part, of course, is what underlies the diagnostic test for the electrocochleography. But in terms of the VEMPs, say if someone had the distended saccule, then you might expect that to alter the fluid mechanics and then the tuning curve accordingly. And so what we have here is the results from a study again by Sanhu and others some years ago. And first of all, we see in the dotted line the normal range of the VEMP tuning curve, which rather which corresponds to the results that I showed earlier in that other study by Park and others. That's for the normal results. But then in 8 individuals with a diagnosis of definite Meniere's, then what we see is enlarged VEMP amplitude, certainly in the higher frequencies. But interesting to note that the 500 Hz VEMPs were actually in the normal range. So this is a good indication that if using 500 Hz as your standard stimulus in someone with suspected Meniere's, then whether or not that response is in the normal range in terms of its amplitude, it would still be advisable to go on and measure the VEMP tuning curve at those other frequencies, because based on these results, it's clear that it's in these higher frequencies where the abnormalities would be expected to be revealed. So, as I mentioned, the precise reason for the sort of changes are unclear, but that distension of the saccular and the utricular zone just seems to, I think the view is that the altered biomechanical properties in turn alter the frequency tuning curve. Okay, so that brings me to the end of the talk on high drops. Now I'm just going to close with this brief mention of just for review and reference purposes, the common findings for the oVEMP and how that's integrated with the CVEMP and the video head impulse test, which together constitute a very powerful assessment of the vestibular system. Of course, not to overlook the important role of the whole of the assessment battery, but as a first glance, and this is a slide that's repeated from our CVEMP talk as well. I would very much encourage you to come to our webinar series, take in that CVEMP webinar and the host of other materials and resources that we have available for your benefit. And I'll just bring matters to a close on that note, and thank you very much for your attention.